Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yasin Taha from the College of Medicine, University of Sulaimani, giving a talk on surgery for tuberculosis of the chest. You can download this lecture from my YouTube channel by visiting this website. I have chosen this stamp, which was released by the Anti-Tuberculosis Society in Iraq. This society was founded in 1944 and played a significant role in fighting the disease in our country. Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis. And this is a bacillus, also called acid-fast bacillus, demonstrated by a special stain called Thiel-Nielsen stain. 2 billion people are affected worldwide, and 2 million die each year from the disease. Hence, the disease deserves the name Captain of Death. Poverty, collapse of health infrastructure, weak national TB control programs, and the impact of HIV are all responsible for increased global burden of the disease. Mycobacterium tuberculosis was discovered by Robert Koch in 1882 on March 24, and that day was recognized by the WHO as the World TB Day. And the Anti-Tuberculosis Society in Iraq, as I told you, was established in 1944 to fight the disease. The national TB program in Iraq aims at TB-free country with elimination of the disease as a public health problem by 2050. TB has infected humans for thousands of years. Spinal columns of Egyptian mummies show definite pathological evidence of TB. It was also known as feces or consumption, means wasting, due to the cachexia of the patient, and also one time was called white plague of Europe due to patient's pallor. Robert Koch is credited for his discovery of Mycobacterium tuberculosis and also for discovering a staining technique that enabled identification of the tubercle bacillus and definite diagnosis of the disease. Moreover, he discovered the intradermal tuberculin test, which has a diagnostic value, especially in children. In 1895, Roentgen discovered the X-rays, which enabled early diagnosis of the disease. Although pulmonary TB can produce a variety of abnormalities, the classic finding is multinodular infiltrate above or behind the clavicle, or with or without pleural effusion. Salman Abraham Waxman was awarded the Nobel Prize for his discovery of a drug called streptomycin in 1952, and the discovery of anti-TB drugs between 1944 and 1946 was a significant landmark in human fight or human battle against the disease. Transmission of the disease is through droplet spread from undiagnosed or confirmed infected cases via breathing, coughing, sneezing, talking, or singing. The incubation of the disease is 4 to 12 weeks, but latent infection may remain dormant for years. Smear-positive cases are highly infectious. Each smear-positive case will transmit infection to 10 to 15 persons in a year. Those who will be infected with TB will not necessarily get the disease. The immune system walls off the TB bacilli, which can remain dormant for years. About 5 to 10% of the infected individuals have chance of developing TB disease during their lifetime. The diagnosis of the disease is based on clinical features. We have to suspect tuberculosis in any patient who has cough for more than 3 weeks, not responding to ordinary treatment. Bacteriological examination of 3 consecutive sputum samples is the only way in which the diagnosis of pulmonary TB can be confirmed. Smear-negative cases require culture. Although certain radiological abnormalities are consistent with TB, X-ray diagnosis of TB is unreliable, as other chest diseases can look like TB on X-ray. The tuberculin test has a limited value in clinical work in adults, but it helps in TB diagnosis in children. Treatment options for pleuropulmonary tuberculosis. Throughout the history, different therapies were used for TB. The role of each therapy varied over the time. Some therapies were standard at one time, became obsolete later on. On the other hand, new therapies emerged. In this lecture, we will discuss these therapies, and we will see that some patients still benefit from all therapies used together with the new therapies. This fact emphasizes the importance of the individualized approach for patients' management. For the thoracic surgeon, pulmonary TB is not a disease per se. It is a school from which valuable experience was gained and applied later in the management of other diseases. Current role of surgery. Currently, surgery has a minimal role in the treatment of pulmonary tuberculosis because management is primarily medical. Surgery for tuberculosis is generally performed for 3 broad groups of patients nowadays. Number 1, those in whom surgery is necessary to make the diagnosis. Number 2, those with complications of the disease. And number 3, those who have active disease resistant to therapy, in whom surgery is performed with the goal of disease control. So that is the first type of therapy used for tuberculosis, TB Sanatorium Therapy, prior to anti-TB drugs discovery. Left untreated, up to 2/3 of patients infected with TB will die without the availability of effective drugs. That's why, starting in the 19th century, TB patients were forcibly isolated in sanatoriums built in remote areas or locations all around the world, where they were provided with the top treatment of the day, fresh air and sunlight. Now, this is Prince Abdullah or Tuwaitha or Ibn al-Khatib Hospital for chest diseases opened in 1951 in Baghdad. This 1,000 beds isolation hospital was built in a 3-year period entirely via donations of the wealthy of Baghdad under direction of the Anti-Tuberculosis Society in Iraq. Worthy to note, this hospital is currently used for isolation of COVID-19 patients, and unfortunately, it has sustained a big fire on the night of 24 to 25 April 2021. Nowadays, do we need case isolation? Smear positive cases should be isolated until convert into smear negative status is proven. Isolation is also necessary for HIV TB patients, though they are often smear negative for TB. Cavitary pulmonary cases are usually smear positive. Therefore, they should be isolated as well. Now, the situation is hospitalization rather than isolation for certain patients. Hospitalization in itself has little or no effect on the outcome of treatment. A patient who takes the drugs regularly will do equally well whether treatment in or out of the hospital is given. However, regular and direct supervision of patients is important. Inpatient treatment is indicated for severely ill and for those with complications of TB, such as hemoptysis and spontaneous pneumothorax, and for those with other serious coexistent diseases requiring hospitalization. So there's a difference between the isolation or the sanatorium or the inpatient treatment for certain indications. History of TB surgery. The first thoracic surgical procedure, an open drainage of a TB pleural empyema, was performed by Hippocrates. During the first half of the last century, the finding that Mycobacterium tuberculosis was an obligate aerobe led to rapid growth of thoracic surgical operations such as Thalakoplasty, induced pneumothorax, induced pneumoperitoneum, plombage, and phrenic nerve crushing. All these procedures belong to a category called collapse therapy. Thoracoscopy was also first introduced around 1900 by Jacobius as an approach for pleural biopsy and adhesiolysis in TB patients. The discovery of streptomycin 1944 and rifampicin 1960s modified the therapeutic protocol, leaving still a little place for surgery. As bronchogenic carcinoma increased in incidence, thoracic surgeons began to utilize the skills they gained in TB surgery in fighting bronchogenic carcinoma. What are the types of surgical approaches for tuberculosis of the pleura and tuberculosis of the lung? Drainage procedures, including closed tube thoracostomy, rib resection, open window thoracotomy, video-assisted thoracoscopic drainage, lung decortication, collapse therapy, pulmonary section plus collapse therapy, such as Thalakoplasty, and sometimes interventional bronchoscopy for TB bronchial stenosis. So if we start with closed tube thoracostomy for drainage of empyema, as you know, chronic empyema requires drainage via a wide bore chest tube, whether the empyema is pyogenic, tuberculous, or mixed empyema. Sometimes closed tube thoracostomy fails to efficiently drain the empyema for a number of reasons. Either the drainage is non-dependent, the tube is placed above the level of the empyema, or the tube is inserted too far, or the pus is thick, or there's a bronchopleural fistula, or the tube is too small, or we have foreign bodies blocking the chest tube. The second procedure used to drain empyema is rib resection, and this operation is performed by making a vertical incision over the proposed ribs, then subperiosteal resection of a segment of a rib is done, and then the bed of the rib is opened, the pus is released, and adhesions are also divided, and the wide bore chest tube is placed in the empyema cavity, and the wound is closed in this way. The third method for drainage of empyema is called ilo-isser flap, or the open window thoracotomy. This operation was developed by Dr. Leo Ilo-Isser in 1935 in San Francisco General Hospital. It was extensively used before the discovery of anti-TB drugs in the late 1940s and early 1950s. In a recent case series, the most common reasons to need an ilo-isser flap were parapneumonic effusions and post-resection empyema, while it was done in 9% of cases for TB. The procedure is performed by doing or making a U-shaped incision in the skin, and then a flap of the skin and subcutaneous tissue is raised. The proposed ribs are resected subperiosteally, sometimes one rib or more than one rib. Then the bed of the rib is excised, the empyema or the pus is drained, adhesions are released, and then the skin fold is turned to the interior of the chest and fixed by sutures. The wound is partially closed, and a permanent communication is left between the empyema cavity and the exterior. Decortication is a major operation performed for an entrapped lung because of chronic empyema, and the most important technical tip in the operation is to have a healthy underlying lung and to have or to find the proper plane of cleavage between the visceral peel and the surface of the lung, so that the thickened visceral peel and parietal peel of the pleura are removed completely without damaging the lung. Of course, the aim of the operation is to allow or to achieve a full expansion of the lung. What about collapse therapy? Collapse therapy is based on the concept that collapsing the affected portion of the lung allows the disease area to rest and recover. The efficacy of collapse therapy probably is derived from lowering of oxygen tensions in the collapsed portion of the lung, thereby inhibiting the growth of Mycobacterium tuberculosis, which is a strict aerobe. There are different types of collapse therapy, such as artificial pneumothorax, induced pneumoperitoneum, unilateral phrenic nerve crushing, extraperiosteal thoracoplasty with Plum badge, standard paravertebral thoracoplasty. For example, this is a plain X-ray of the chest after induced pneumoperitoneum to treat pulmonary TB of the superior segment of the left lower lobe. What about Thalakoplasty? Thalakoplasty is the decostalization of the chest wall. The standard or the original Thalakoplasty involves removal of the whole ribs on one side of the chest. However, Thalakoplasty was later on tailored, so tailoring Thalakoplasty is done in 3 stages. In the first stage, we remove ribs 1, 2, and 3. In the second stage, done after 2 weeks, we remove the 4th segments of the 4th and 5th rib. And in the third and last stage, we remove ribs 6 and 7 in a tailoring fashion, leaving more ribs anteriorly each time after the 3rd rib. So if you look at this diagram, this is a demonstration of right-sided 7-rib Thalakoplasty, in which ribs 1, 2, 3, 4, 5, 6, and 7 are resected. Ribs 1, 2, and 3 were removed completely. However, ribs 4, 5, 6, and 7 were removed partially, and each time more anterior portion of the rib is left anteriorly. Extrapleural paravertebral Thalakoplasty was the most frequently employed surgical procedure for the treatment of pulmonary TB before the discovery of effective chemotherapy for this disease. Closure of cavities was achieved in more than 80% of patients without chemotherapy by using Thalakoplasty. However, today, this operation is rarely indicated as a primary treatment for TB. One of the disadvantages of the operation is the patient's disfigurement. So this is the posture of the patient after Thalakoplasty, after 7-rib left-sided Thalakoplasty. The grossly diminished left shoulder movement and the marked scoliosis are shown. The deformity is irreversible, therefore prevention is essential. Prevention by good post-operative physiotherapy and rehabilitation. Another form of Thalakoplasty is called Plum badge Thalakoplasty. As you can see in this diagram, the ribs are not removed, but the plastic balls enclosed in plastic envelope are introduced out or side the pleura to achieve the same purpose of collapsing the underlying lung parenchyma. Plum badge Thalakoplasty is a procedure designed for TB treatment based on the idea that collapse of the underlying parenchyma favors healing of the scoliosis, or healing of the lesions. It was extremely popular in the 1940 to 1960s. The main advantages being the simplicity of the procedure and the absence of an important chest mutilation like after Thalakoplasty. The procedure was very well tolerated by fragile patients. So this is a CT scan of a patient with Thalakoplasty. An 81-year-old patient underwent a Plum badge Thalakoplasty with balls at the age of 35. CT scan performed 4 to 6 years after surgery, showing the plastic balls. Another CT scan of a patient with Plum badge Thalakoplasty with lucid balls. And this is a photo of boys and watermelons in old Baghdad. The similarity between the watermelons and the balls used in a Plum badge Thalakoplasty attracted me. And this is an X-ray of a patient with bilateral Thalakoplasty. On the right side, 7 ribs Thalakoplasty was performed, while on the left side, a Plum badge Thalakoplasty was performed. Another form of Thalakoplasty is called paraffin Thalakoplasty. In this procedure, paraffin wax is used to fill the space outside the pleura, and therefore the procedure sometimes called paraffinoma. And it is evident that the plain X-ray appearance may suggest a tumor or a cyst if a proper history was or is not obtained from the patient. Paraffin plombage of the chest sometimes is complicated by the development of a chest wall mass and discharging sinus, such as this case report described in this paper. Another alternative to the thoracoplasty and the plombage thalakoplasty is myoplasty. In our days, most authors prefer to perform a plombage using well-vascularized flaps, which act as a biologically active material with no risk for long-term complications. The harvested pedicled latissimus dorsi and serratus anterior muscle graft can be transferred to the affected side to fill out the residual post-resectional space, or for the reinforcement of the bronchial stump. So if we look at this diagram, muscles such as the serratus anterior with its blood supply, the lateral thoracic artery, and the latissimus dorsi with its blood supply, the thoracodorsal artery, can be mobilized as a graft and introduced into the chest cavity to fill a space in the chest cavity. Another category of surgery for pulmonary TB is pulmonary resection. Resection of the diseased portion of the lung, which can be in different forms, such as wedge resection, segmentectomy, lobectomy, bilobectomy, pneumonectomy, or sometimes pleural pneumonectomy. The extent of resection depends on the extent of the mycobacterial disease, but all gross evidence of the disease should be resected. Nowadays, the indications for pulmonary resection for TB include the following. Number one, persistent positive sputum cultures after 3 months of therapy. Number two, localized pulmonary disease due to atypical mycobacteria such as Mycobacterium avium intracellularly or drug-resistant mycobacterial tuberculosis. Number three, a mass lesion of the lung, which is suspected to be a bronchogenic carcinoma. Number four, massive, life-threatening or recurrent severe hemoptysis, in which lobectomy is the preferred operation. Number five, a bronchopleural fistula secondary to mycobacterial infection that doesn't respond to tube thoracostomy. 6, destroyed lobe or lung. 7, TB bronchiectasis. 8, thick-walled cavities. 9, non-compliant patient. 10, trapped lung, which requires decortication. 11, secondary fungal infection of the TB cavity, aspergillosis. And 12, tuberculoma. So what is pulmonary tuberculoma? A pulmonary tuberculoma is a well-circumscribed nodule or a mass located in the lung and caused by Mycobacterium TB. Pathologically speaking, it is a caseous mass encapsulated by multiple concentric layers of connective tissue without surrounding inflammation or spread. This is an example of destroyed left lung or autopneumonectomy, which is an indication for surgery in TB if the patient is symptomatic. And this is a CT scan of the chest of a patient with left lower lobe bronchiectasis, another indication for surgery also. What are the advantages of lung resection? Prompt conversion into sputum negative state in a single session. No chest wall deformity is produced like in Thalakoplasty, and no limitation of ventilatory capacity like in Thalakoplasty. What are the contraindications for lung resection? Widespread pulmonary or endobronchial disease. And number 2, children with mycobacterial disease, they rarely require lung resection. Pre-operative measures before lung resection: adequate cardiopulmonary reserve, conversion of the patient into sputum negative status is desired, adequate physical and pulmonary toilets, adequate nutritional support, pre-operative bronchoscopy. Intraoperative measures: the use of a double lumen endotracheal tube can make operation for TB technically easier and safer. Bronchoscopy may be required at the end of the operation to clear infected secretions or blood from the airway. The complications of lung resection: empyema with or without bronchopleural fistula, bronchogenic spread of mycobacterial disease. Both complications are more frequent when the patient is sputum positive at the time of operation. Wise use of Thalakoplasty or liberal use of muscle flaps in such patients at the time of operation can minimize the incidence of bronchopleural fistula and apical space problems. Results of resection are very good. The decreasing morbidity and mortality of pulmonary resection for TB is due to careful patient selection, such as using or choosing patients who fail after failure of chemotherapy or massive hemoptysis or bronchopleural fistula, improved anesthetic techniques, stapling devices, better chemotherapy. Operative mortality of pulmonary section prior to chemotherapy was very high, 20 to 40%, but was very much reduced after using chemotherapy. The prognosis after successful resection is excellent. 90% of the patients survive and remain disease-free. Well, sometimes we have patients with TB bronchial stenosis, which can be managed by a different mode of therapy. It is the interventional bronchoscopy. And this is an example of a patient with TB bronchostenosis with segmental atelectasis. The patient, I have seen this patient in London, UK. The patient was managed by rigid bronchoscopy and introducing a balloon over a catheter, and then inflation of the balloon to dilate the area of the bronchial stenosis successfully. And this is the bronchogram done at the end of the procedure. So what are the take-home messages of our lecture of today? The proper care of patients with pulmonary TB should be provided by a team of infectious disease specialists, respiratory physician, radiologist, and a thoracic surgeon to identify cases in need of surgery. Select patients on the basis of certain indications, TB drugs before and after surgery, adequate preoperative pulmonary function, negative sputum smear is highly desired, preoperative bronchoscopy to rule out endobronchial TB, correct malnutrition and anemia, and tailor the procedure to each patient. And always remember the saying of our professor Nazar Baqir al-Hassani: tuberculosis may simulate any pathology of the chest. This is the bibliography of our lecture, and this is a photo of old houses in Slimani city. And this is the end of our lecture. This is Dr. Abdussalam Yassin Taha signing off from the College of Medicine, University of Sulaimani. Thank you for listening and watching.